Good afternoon, ladies and gentlemen. Let me start the current lecture, which is about adverse drug reaction classifications. My name is Alexander Matveev. I'm the Associate Professor of Clinical Pharmacology in our department. And during this lecture, I will show you the modern approach to the classifications of adverse drug reactions according to their severity, according to their types, and I will show you some examples of different adverse drug reaction types. And in the second part of our lecture today, we talk about approach, modern approach to casualty assessment for adverse drug reactions and adverse events according to World Health Organization method. So let's start from some history aspects, and it's proud to say that the first classification of adverse drug reactions was introduced by Russian doctor, Russian scientist Alexei Filomofitsky in very far 19th century in 1836. This classification included three types of uh, adverse reactions. You see them on this slide, and it may be a bit bizarre, but Alexei Filomofitsky, uh, more than 100, about 200 years ago, found three basic types of adverse drug reactions which we use today. The first one is antipathy, which is equal to type A reactions today, unusually strong action of drugs. That means very strong basic pharmacological effect. The second one is heteropathy, a natural correlation of external phenomenon to general law of excitation. You should understand that 200 years ago there were another theories in medicine, and one of them was imbalance of external excitations and internal response to this external stimuli. So heteropathy, a natural response. Uh, Today we call such type of reactions as reactions type B, according to Rowland-Thompson. I will show you on the next slides. And the last one is apathy, so which is unusual phenomenon that doesn't lead to excitation. So the lack of therapeutic effect, according to modern approach, is so named type F reactions. Okay, let's see to the Rowland-Thompson classification. Rowland-Thompson are family names of two famous clinical pharmacologists which worked in MHRA. It's a regulatory organ of United Kingdom, where the first techniques and the first methods of how to analyze adverse drug reactions were introduced. And Rowland-Thompson noticed that all information, all messages, all reports about adverse drug reactions may be easily divided on two big groups. They call them type A and type B reactions. What's the difference between type A and type B? Look on this slide. You see that type A reactions are dose-dependent reactions. So when you increase the dose, you increase the strength of reaction. They are usually predictable. So we may say that if we will continue to increase the dose, we will see a more strong effect, more strong manifestations of reactions. They are quite frequent. Usually we may find them during clinical trials, and we describe them in clinical trials. Uh, Therapeutic approach to this type of reactions is usually to stop drug or decrease the dose of drug. It's also very effective methods how to uh, decrease decrease the strength of this reaction. The classic example of type A reactions is, as you see, the bradycardia resulted from metoprolol use or any other beta blocker use. We prescribe beta blockers to decrease the heart rate, and when we increase the dose of beta adrenal blocker, we we may cause bradycardia and even AV blockade. Another situation with type B reactions. As you see, type B reactions are usually not dependent on dose. They are very difficult to predict, to prognose. They are unpredictable reactions. According to, in comparison with type A reactions, type B reactions are more rare. Uh, the mortality of type B reaction is significantly higher. And the main period where we see the type B reactions is a post-authorization phase, so when drug is already registered in the market of the country. So during routine use of the drugs, type B reactions may be found more easily than during the clinical trials phase. The main and maybe only effective approach to type B reactions is immediately stop taking the drug, immediately stop infusions or injection of drug, or to take drug orally. The decrease of dose will not be effective in type B reactions. And the example of type B reaction is allergic reactions, angioedema or anaphylactic shock, for example, after ceftriaxone use. Risk factors for type A reactions. As you see, we may divide risk factors again on two big groups, kinetic and dynamic ones. And of course, it's a kidney disease, it's a liver disease, heart failure. So any problems with inner organs which participate in drug kinetics and increase the dose, increase the plasma concentration in for current drug. The same situation with elderly, older patients, and small patients. So childhood and old age are also risk factors for type A reactions. You should be very careful when you prescribe drugs with narrow therapeutic range, when you use drugs with manufactured in extended release drug forms, forte forms, rapid forms, and so on. Don't forget about role of excipients. And for example, here you may see the real case for diethylene glycol as a component of acetaminophen suspension cause very uh, dramatic cases in Bangladesh and even death of small patients, of children. And this reaction was caused by excipients. Uh, and one very important factor which you should remember when you prescribe drugs, it's a possible drug and drug food interactions. Uh, as you remember from our first lectures, we have critical points, critical processes in our organism and drug metabolism, for example, biotransformation in liver, and one drug may influence on kinetic of another drug and change the plasma concentration of it. For example, some of cytochrome inhibitors may significantly increase the plasma concentration of another drug and so uh, cause type A reactions. Type B reactions are usually allergic and pseudo-allergic reactions. Approach to classification of allergic reactions is classical according to Gell-Coombs classification. We have four different types of allergic reactions. Here in the table on this slide, you may see the main differences between different types of reactions by Gell-Coombs. First one, immunoglobulin E dependent degranulation of mast cell and basophils. Second type of reactions for which immunoglobulin G, M, and A interact with antigen. In our case, antigen are antigens are drugs on the surface, and this interaction resulted in activation of complement system, of immune system, destruction of cells. Third type of reactions, very similar to the previous, but mediated not by immunoglobulins, mediated by circulating immune complexes. And the last one, according to this classification, when drug excess HAP10 and formation of antigen results in cytokine release and migration of immune cell. The latter type of reactions, cell-mediated reactions, and for any of these types of reaction, we may find examples in drug reactions. For example, for first type, it's for first type of Gell-Coombs reaction, anaphylactic shock, alveolar edema, urticaria, rash, bronchospasm, usually immunoglobulin E-dependent types of reaction. For second type, blood system reaction, such as anemia, thrombocytopenia, and so on. Third type of reactions, all nephritis, vasculitis, fever, and for the last type of reactions, as example, we may use formation of contact dermatitis, photosensitizations, and so on. All of hypersensitivity reactions are type B reactions according to Rowlands-Thompson approach. Frankly speaking, when we say that type B reactions are not dose dependent, it's not absolutely correct, because you see, according to this slide, to cause any type of reaction, we should reach some threshold in plasma concentration. So these reactions are not dose dependent. The strength of reaction is not dose dependent. But to cause these reactions, we should form effective plasma concentration, and we should reach this threshold, after which reaction is started, and then the change of drug dose does not influence on drug reaction strength. So we say type B reactions are not dose dependent, but it is not absolutely correct. I want you understand this small but very effective but very important detail of type B reactions. So the presence of drug molecules in the organism is necessary for any adverse drug reaction development, but the strength of type B reaction does not depend on drug dose. Pseudoallergic reactions also belong to the type B, according to Rowlands-Thompson. I want to remind you that pseudoallergic reaction usually develop without immunological stage, which is necessary for allergic reaction. immunoglobulin E, other types of immunoglobulins or immune complexes or immune cells. For pseudoallergic reaction, these components do not play important starting role of reaction. So antibodies do not take part in pseudoallergic reaction. Inflammatory mediators for this type of reactions are usually released directly after interaction of drug with the mast cell. Uh, there are some very important clinical aspects, clinical details of pseudoallergic reactions. The first one is very important, that allergic anamnesis does not play very important role in prognosis of pseudoallergic reaction. So if your patient says that it has pseudoallergic reaction in the past, this fact does not mean that your patient will have pseudoallergic reactions during this case, or it does not mean that you should not prescribe this drug for this patient. Uh, Usually, but not necessarily, these reactions are dose dependent. Real, true allergic reactions, as we already discussed, are not dose dependent. Pseudoallergic reactions are dose dependent. Usually, these reactions are quite short, and if your patient has pseudoallergic reaction, you should not obligatory stop the therapeutic use of this drug. You should wait some period of time and then prescribe this drug again, and you will not get the pseudoallergic reaction because all depot of histamine will be empty, and you will not cause pseudoallergic reaction again. But sometimes it's very difficult to differ pseudoallergic reactions from real, true allergic reactions. Here are some examples of pseudoallergic reactions you should know for drugs. For example, the red man syndrome for vancomycin. All iodine contrasting drugs, which we use in rentgenology, which we use in other areas of medicine, also may cause pseudoallergic reaction. We know that rash and pruritus itching which is caused by opioids, cells of pseudoallergic reaction, and rash and caused by ciprofloxacin or other fluoroquinolones also belong to the type of pseudoallergic reaction. Here on this slide, you may see photos of Redman syndrome caused by vancomycin. It may be very strong reaction. It causes the fear of patient, but because this reaction is pseudo-allergic, it's very important to explain for our patient or his relatives about the real nature of pseudo-allergy, and it will be very important for antibiotic therapy uh, to, because real allergic reaction need to stop our therapy, but pseudo-allergic reaction such as Redmond syndrome, which is not strict contraindication for continuation of therapy. In 1984, Graham Smith and Jeffrey Aronson noticed that two types of reaction are not enough to describe all possible types of reactions which we may find in the national safety databases. That's why two new types of reaction were introduced, such as type C. Type C reactions are reactions which develop after long chronic use of the drug. For example, withdrawal syndrome, drug dependence, cumulative effects, suppression of hormone production are examples of type C reactions. And here we should also notice what is tolerance and tachyphylaxis. Here you see the definition of these two phenomena, and we will not stop on these definitions. We may see on these photos. Um, it's Cushing syndrome, which is caused by inhibition of adrenocorticotropic hormone production, iatrogenic condition. We see the moon phase, we see the stria, buffalo hump, and obesity, specific type of obesity, specific for glucocorticoids. It's not obesity by male or female types. It's a formation of apron-like obesity. Cushing syndrome is example of type C drug reaction. Type D reaction, delayed effect, carcinogenic, mutagenic, teratogenic, embryotoxic influence. Very difficult to diagnose because of very long time span between drug intake and development of sequelae of drug influence. Classic example of type D reactions are teratogenic reactions. Here on this slide you see effect of thalidomide, influence of thalidomide on our genes. Thalidomide was a sedative drug which was positioned as drug for pregnant women, and there is still more. On this slide you see photos of patients after thalidomide used by their mothers. Thalidomide pass the placenta barrier and interact with genes, with DNA, and cause formation of phocomelia. Phocomelia, which is describe the formation of specific extremities, lower extremities and upper extremities, without significant influence on mood sphere, mental sphere. So there is a patient with absolutely normal mental status. As you see, twins, so there is still unknown how thalidomide choose the genes to which it interacts. So these twins, one with normal extremity, normal hands, and his brother with phocomelia. Also, you see the photo of Speaker of Switzerland Parliament during his speech on court for on court where the case of thalidomide manufacturer was investigated. Frankly speaking, without thalidomide, we would not have a modern system of pharmacovigilance, modern system of clinical trials, of preclinical trials. So thalidomide started investigation of adverse drug reactions, of adverse effects, side effects of the drug, and the system of how to investigate these effects. Also, in the beginning of 21st century and end of 20th century, two additional types of reactions were introduced in the classification of Rowland-Thompson. These two types are type E reaction, it's withdrawal effect. So it's essentially subdivision of type C reactions on two big groups. Withdrawal effect is separate type E and all other, which we already discussed, as type C effects. It's a correct approach because uh, withdrawal effect in many cases do not need long use of drug. And sometimes withdrawal effect may be caused even after 1 or 2 days of treatment. So it's more correct to say that withdrawal effect is a separate type of reaction source. And we call this adverse drug reactions type E reactions. And the last one is type F, unexpected absence of therapeutic effect, lack of effect. Uh, if we uh, analyze the definition of adverse drug reaction, what is adverse drug reactions, we will see that unexpected absence of therapeutic effect is absolutely um, the same as adverse drug reaction. It is unexpected and it is harmful for patient. And all mechanism of how to analyze, how to recognize absence of therapeutic effect are the same as for adverse drug reaction. So it's absolutely correct to say that unexpected lack of effect is adverse drug reaction, type F, adverse drug reactions. This uh, mnemonic uh, rule, how to remember types of reactions. You see A, augmented, uh, more strong than usual pharmacological effects. B, bizarre. C, chronic, long use of drug. D, delayed, so reactions which we may find after uh, stop or withdrawal of drug. E, end of treatment, and the last one, F, failure, so lack of effect. Rowland-Thompson classification has some issues, has some problems. It's true. For example, Rowland-Thompson classification does not consider so important issues as procedural mistakes, uh, microbial resistance, and others, which they can approach in other uh, classifications, such as Williams-Brown classification or Eidos-Dodds classification. But nevertheless, none of these classifications became widely used as Rowland-Thompson, and this may be explained first by uh, difficultness of this classification, of this new approach. Rowland-Thompson classification main advantage is very easy to use approach, very easy to use classification. That's why we continue to use Rowland-Thompson approach, even uh, in case that we know about its problems with microbial resistance and so on. Now let's talk about another characteristics of adverse drug reaction, and the first one I want to start from is the frequency of adverse drug reactions. Here you see the approach of International Conference of Harmonization, World Health Organization division. And according to this approach, we have reactions, very common ones, which develop more than 10% of patients taking a drug. So one patient from 10. Common reactions develop in from 1 to 10% of patients taking a drug, so one patient from 100. Uncommon developed in 0.11% of patients taking a drug, so it's one case per thousand of patients. Rare developed in 0.01 0.1% of patients taking a drug, so one case per 10,000 of patients, and very rare developed in less than 0.01% of patients taking a drug. And sometimes in short medical product characteristics, the leaflets, package leaflets, you may find frequency marked as unknown. Unknown means that we have a single cases of adverse drug reactions in our safety database. So it may be one patient per million, and this information was received during post-authorization phase, not during clinical trials, because this frequency is usually defined during clinical trials. Seriousness of reaction. What is seriousness? Seriousness is a measure of intensity of harm that caused or could be caused to the patient. So it's a measure, in other words, it's a measure of intensity of outcome. So we measure outcome, not reaction itself. And the following case we consider as serious when reactions resulted in death of patient, treat to patient's life at the moment of reaction development, when reaction resulted in hospitalization of patient, prolongation of hospitalization, when it caused temporary or permanent loss of working ability, so temporary or permanent disability of patient, and congenital anomalies. All other cases of outcomes we consider as non-serious. So all others that don't meet mentioned criteria of seriousness belongs to non-serious reaction. And finally, here, severity of adverse drug reaction. Severity is a measure of intensity of reaction itself. If seriousness is a measure of outcome, severity is a measure of reaction. Usually, no, not usually, many doctors confuse severity and seriousness of reactions, which is not correct. And of course, the modern approach to estimating severity of drug reaction is to use clinical classification. For example, we know clinical classifications of anemia according to hemoglobin level, according to erythrocyte level, or we know the clinical classification of arterial hypertension grades, mild, moderate, severe, and so on. But adverse drug reactions manifestations are so various that we cannot use clinical classifications for them, because for many cases we have not such classifications. And that is why some of the approach to estimating of severity of adverse drug reactions is to use surrogate classification, such as NCI-CTCAE classification. NCI-CTCAE is abbreviation, National Cancer Institute Common Terminology Criteria for Adverse Events. It's a quite understandable, quite easy to understand approach. Any clinical manifestation, so any adverse reaction, may have 5 grades from mild to most serious death, most severe death of patient. First grade, mild severity, symptomatic course or mild symptomatology, mild symptoms. Only some diagnostic or clinical signs are present, and intervention is not indicated. Any medical intervention is not indicated for such patients. Second grade of severity, medium severity, when we see local minimal symptoms, interventions may be indicated, but as you see on the slide, they are so minimal or non-invasive interventions. We may say that our patient is restricted by his daily activities. For example, he has problems with cooking, with the use of phones, with the use of credit cards. No, of course, according to his age. Third stage, third grade, uh, severe medical significant grade, not life-threatening condition. Hospitalization or prolongation of hospitalization is indicated. We may see loss of ability to work. We may see restriction of daily activities related to self-care, such as washing, dressing, undressing, eating, and so on. And grade number 4, next grade, life-threatening consequences, emergency intervention is indicated. And the last one, most severe, is death of patient. Okay, let's analyze NCI-CTC approach on these two examples, acute nausea and acute vomiting. As you see, acute nausea has not grades number 4 and 5. Yes, acute nausea cannot lead to the life-threatening consequences and death. That's why it contains only 3 first grades. And we, in CICTCI yearbook, we may find other examples. For example, drug-induced liver injuries, which has not first, second, and third grade of severity, and approach to these types of reaction, drug-induced liver injury, contains only 2 grades, grade number 4 and grade number 5. So any drug-induced liver injury is life-threatening. Let's return to acute nausea. On the upper part of the slide, you see 3 grades. The first one, mild loss of appetite without alteration in eating habits. Grade 2, moderate severity, oral intake decreased without significant weight loss, dehydration or malnutrition. And the severe grade, grade number 3, inadequate oral caloric or fluid intake, tube feeding, parenteral nutrition or hospitalization is indicated for this patient. Another approach for acute vomiting, according to frequency of vomiting during a day. Mild grade 1 severity, when our patient has 1 or 2 episodes in 24 hours. Moderate grade of severity, 3, 5 episodes in 24 hours. Severe grade 3, more than 6 episodes. And for such patient, tube feeding, parenteral nutrition or hospitalization may be indicated. Grade 4, life-threatening consequences, urgent intervention is indicated, and grade 5, death of patient. So here, for this clinical manifestation, for this type of adverse reaction, we have all 5 grades of severity. I want to remind you, severity is not equal to seriousness. Severity is a measure of reaction. Seriousness is a measure of outcome of reaction. So it's possible when adverse drug reaction severe but not serious. Here you see clinical example of such cases. Or vice versa, when adverse drug reaction is serious but not severe or has mild severity. Again, example of papular rash in a child that makes parents to call an ambulance and leads to hospitalization for diagnosis clarification. So, criteria of seriousness is performed, hospitalization, but reaction was not severe. Expectedness of adverse drug reaction is another characteristic, and we may divide all reactions on expected and unexpected reactions. Expected are those described in the instruction for medical use, in the package information leaflet of a drug, and unexpected are those which is not labeled, not described in this paper, in this document, instruction of medical use of package information leaflet. All modern instruction for medical use for drugs must contain not only list of possible adverse drug reactions, expected adverse drug reactions, but also must contain information about its frequency. And in case when frequency is indicated incorrectly, not equal to real practice, we also may say that these reactions are unexpected reactions. So frequency and nature of reactions is also very important when we say about expectedness of reaction. Predictability. Predictability, as you see, is a possibility to foresee adverse drug reaction development. And this possibility is based on your knowledge of mechanism of adverse drug reaction, uh, your knowledge about patient condition, patient disease, pathogenesis of patient disease, mechanism of drug action, your knowledge about uh, pharmacokinetics of the drug, your knowledge about possible drug and drug food interactions, and so on. And usually we say that all reactions of type A and type C are predictable. Reactions of type B, pseudoallergic reactions, are unpredictable. Preventability. It's also very important characteristic of adverse drug reaction. And we may say that preventability is a measure of our ability to decrease the likelihood of reaction development and possibility of its complete elimination. Uh, Frankly speaking, we may divide all adverse drug reactions on two groups, avoidable and, and unavoidable, or preventable or unpreventable. But if we analyze the literature about drug safety, we may find a few classifications of adverse drug reactions by its preventability. Here you see the one example classification by Halas, which divided adverse drug reactions on four groups. Definitely preventable event, so reaction was due a drug treatment procedure inconsistent with present-day knowledge of good medical practice, possibly avoidable when or preventable when reaction could have been avoided by effort exceeding the obligatory demands of present-day knowledge, unpreventable reaction could not have been avoided by any reasonable measures, and unclassified when rentability cannot be estimated, when the data which we have are insufficient or inconsistent. So, as you see, we now may give a quite complete characteristic for any adverse drug reaction. For example, here we have a clinical case of 65 years old patient which was hospitalized with second-degree AV blockade associated with the use of beta blocker, for example, metoprolol, in maximal therapeutic dose. And our task is to characterize this adverse drug reaction. What we may say, it's AV blockade caused by beta blocker. So it's a type A reaction. This reaction is well known. If we open the package information leaflet, we may see that this reaction is frequent. This reaction was severe because AV blockade, according to NCI-CTC classification, NCI-CTC approach, belongs to the third severe grade of reactions. It was serious. Why? Because it resulted in hospitalization of patient. Hospitalization or its prolongation is criteria of seriousness. So reaction was serious. This reaction was expected because we know the mechanism of beta adrenal blocker action, and this reaction is mentioned in package information leaflet. This reaction was predictable uh, because it's type A reaction, and this reaction was avoidable, preventable, because we had alternatives. For example, IF blockers. We had to monitor the ACG of our patient, and we could not increase the dose of beta blocker for maximal therapeutic dose. So you see that for any case of adverse drug reaction, now we may easily give uh, almost complete characteristic. Let's try to do the same analysis for any adverse drug reaction case you know, or which you see in your uh, practice. It's very helpful to remember how to classify adverse drug reactions. In the second part of our lecture, as I already said before in the beginning of our work today, we should talk about assessment of causality and the modern approach how to find evidence that drug is associated with adverse drug reaction. So the detection of causality drug adverse drug reaction assumes obtaining the evidence of an involvement of suspected drug in reaction development in patient. In different countries, there were differences in classifications in the approach to the causality assessment and confusions about different terms of causality assessment and methods which were used in different countries. But now we have one universal approach which was recommended by World Health Organization or by Uppsala Monitoring Center. It's a collaborative center of World Health Organization which is responsible for safety drug safety on our planet. Uh, why we need to estimate causality for adverse drug reaction? It's extremely important for development of our future tactics of treatment, of therapy for patients. It's also very important for risk management provided by regulatory authority, risk management ensured by manufacturers of drug. And it's important to make correct regulatory decision, for example, to withdraw drug from the market or to temporarily suspend drug circulation on the market or to initiate new clinical trials to analyze safety more detailed and so on. So, without assessment, without studying of uh, involvement of drug in drug reaction process, we cannot uh, we cannot find the correct decision for therapy, for drug, and for manufacturing company. So when we uh, perform assessment of causality, we should first establish clinical diagnosis. It's very important to differ symptoms of disease from symptoms of adverse drug reactions. But also, we should evaluate the drug history, its precise timeline breakdown, so we should know when the first signs of drug reactions were noticed by patient or by doctor. Maybe the first signs of possible reactions were found before start of treatment. So in this case, it cannot be signs of drug reaction. Or another case, our patient already been taking the drug more than 1 year, and in this case, again, the evidence for drug reactions decreases and becomes more weak. Uh, don't forget about other diseases, especially in old patients. We uh, have the problems of polymorbidity, and the signs which you see may be signs of another disease, not uh, basic disease for which you use your drug. Maybe also a signs of other uh, drug effect. So when you suspect one drug, you should not forget about another drug in the therapy list. Uh, assessment of repeated intake. So, name it day challenge and re-challenge. Day challenge means withdrawal of drug and dynamic of signs after withdrawal. And when we prescribe the drug again, the same signs should be returned. And these two uh, methods, so withdrawal, the challenge, and repeated intake, re-challenge, uh, are very critically important in the correct estimation of causality rate. So, which types of causality by World Health Organization, Uppsala Monitoring Center, we have? Certain, certain the first type when uh, we sure that the reaction is caused by suspected drug, you see that for this type of reaction, we may see that event, adverse event, or laboratory test anomaly has a plausible time relationship to drug intake. The signs we see cannot be explained by disease or diseases in case of polymorbidity patient or other drugs in case of polypragmasia, polypharmacy. Response to withdrawal plausible. So event definitive pharmacologically or phenomenologically. So uh, we have not other reasons to explain the signs we see. Rechallenge is satisfactory. So challenge test, I mean, when we stop, when we cancel the drug, signs becomes more weak or disappear. But when we prescribe the drug again, we see the same signs, the same symptoms of adverse drug reaction again. We are a bit less sure for probable likely types of causality. You see that even so laboratory test abnormality has a reasonable time relationship to drug intake. These reactions unlikely to be attributed to disease or other drugs or professional or influence or to diet of patient. So there is no food allergy and so on. Response to withdrawal of drug is clinically reasonable, so the challenge test is positive, but rechallenge is not required or is not possible. In many cases, especially when we have patients with severe, with life-threatening reaction, we cannot perform the challenge test. We cannot prescribe the drug again for these patients, especially for allergic reactions such as anaphylactic shock, because we may kill our patients by this recharge, and it's not so good to try to estimate causality for this patient. It's not ethical approach. That's why the challenge not required or not performed due to such reasons. Next, possible type. Adverse event or laboratory test anomaly with reasonable type relationship to drug intake. All the symptoms or signs which we see could be explained by disease or other drugs or allergy or professional influence, professional factors. Information on drug withdrawal may be lacking or unclear. So we may perform the challenge test. We may cancel the drug, but we see that reaction is still present, and maybe some signs becomes weakly, maybe cough becomes more rare or rash decreased, but still present. So effect of withdrawal is not clear. In this case, we may estimate possible type of possible grade of causality. Unlikely or doubtful, as I know, event or laboratory test with a type to drug intake makes relationship improbable but not impossible. Disease or other drugs may provide plausible explanations. And the last one, unclassified, when the information that we have quite controversial, we need additional data. Maybe this data is still under examination. For example, you may wait for autopsy results or plasma concentration results, but in this for this type for this point of type, where we estimate the type of causality, we do not have such data. We may be waiting for it. In this case, we may use such category, such grade, unclassified type of causality. And in case when we have no any chance to get additional data in future, we may use this type of causality assessment, and we may mark our analysis. In our analysis, this reaction is unclassifiable, so we will not get necessary information to estimate correct type, unfortunately. To recognize two different types of causality, we form such table, which, my point of view, quite easy to use. Here you see different types of causality, different grades, and four main characteristics of every grade. Certain, probably, possible, and likely, conditional, inaccessible, classifiable, clinical signs and lab abnormalities, presence of disease and other drugs, other factors. I want to remind you, it may be professional influence, professional risk factors. For example, medical profession, withdrawal of drug, so the challenge test results and re-challenge test results. Also, we have another approach. For example, in European Union, more simple classification is used, A-B0 classification. A type report contains sufficient evidence of causality to consider as plausible, probable, but not in the highest degree. B report contains enough information to recognize the possibility, but it is not impossible and probable. Also, this relationship is not defined and may even be doubtful, for example, due to lack of evidence or presence of other explanation. And the zero reports in which a causality for any reason could not be assessed, conflicting, contradictory, or lacking evidence. More simple that Uppsala Monitoring Center approach, and may be used in the practice. So, one of them, one of possible classification for practical work. And the last one, point-based approach. For example, Naranjo scale or Karsh-Lasagna scale. They are based on the same approach. So it's questionnaires which contain standard questions and standard answers, and each answer has own weight in points, and you should sum the points of your answers, of your responses, and according to the sum, you may estimate the grade of causality. For example, for this case, Naranjo algorithm, you see 10 questions and 3 possible variants of answers, and each variant, as you see, has own weight. The same approach for Karch-Lasagna scale, less questions but more possible standard answers. But the approach is the same. You should sum these points and According to some, you may say which type of causality grade we have for every case. Uh, these algorithms are not recommended for use, and this may be explained by their controversial. So when you analyze the same case by different tools, for example, by Naranjo algorithm and Karch-Lasagna algorithm, you may get different results. For example, you may have uh, doubtful results for Naranjo scale and probable for Karch-Lasagna scale. So these results are controversial. So different experts cannot find the same answers by using different tools. Also, these scales were developed only for monotherapy cases. So when our patient takes only one drug, not many drugs, and they are not good for use in pediatrics. Most of questions there are not for children practice. Also, they contain questions um, which cannot be answered in many cases. For example, do you see the repetition of adverse events after placebo prescription? Or was antidote effective to stop reaction? Or plasma concentrations were toxic or not? So in many cases you cannot answer uh, in these points and in the sequence of questionnaire. So the sensitivity, specificity of these tools are quite low. But we have some exclusions. Some scales, for example, here you see Alden scale, which is used for assessment of causality in cases of Steven-Johnson syndrome or Lyme syndrome, may be used in practice and may be recommended. But this exclusion, for scales, the only recommended by World Health Organization methods to estimate causality is World Health Organization Uppsala Monitoring Center approach, which we studied on the previous slides. That is all for our lecture today. Thank you for your attention. I hope it was interesting. Uh, I hope you will have a questions for me. You may ask, you may write, ask your teachers during practical classes, test yourself in the real clinical situations. When you see adverse drug reactions, try to apply uh, different classifications and of adverse drug reactions and characteristics of adverse drug reactions in real practice. It is very interesting, it's very useful, and I wish you good health. Uh, Stay safe, stay healthy. Uh, Good luck.